Hello, all, and welcome to another enriching episode of the IJA Podcast, where research meets relevance. I'm Dr. Karthik, your host for today. On behalf of the Indian Journal of Anesthesia, I extend a warm welcome to our esteemed editor in chief, Dr. Rakesh Garg, and to all our viewers and listeners across India and beyond. Dr. Rakesh sir, as Indian research continues to gain international visibility, are there any particular areas, for example, like methodology, or ethics or innovation where you feel we are now expected to rise to global standards? Where do you see the most scope for improvement in research coming out of India, and how can young authors practically work towards meeting those expectations?
I think this is important. What I need to say is that India is already on the global platform, and the type of research coming from India is really good. What we need to consolidate is we have to follow certain norms, reporting guidelines norms, so that when we are reporting it, has every component of a good quality study. And this should start not at the reporting time, this should start at the time when you are planning a study. So we look for those reporting guidelines which are very well mentioned at the website of Equator Network, where you will find that what all components or what all ingredients should be a part of any research study. Second thing, what we need to look from our Indian subcontinent is we need to have more of a multi-centric studies. Usually we do calculate the sample size and it is around say 50 patients, 80 patients, 100 patients. So it is based on certain sample size calculation. Then the external generalizability of the study becomes very limited because it is being done at a single center. Once we start going on a multi-centers, that external validity or the generalizability of the study becomes better. And this is what we have to look from our India, that why not to have 3, 4, 5 centers who are working in the same type of infrastructure, same type of patient population, same type of surgery, same type of perioperative care, to come together so that we have a big cohort of the population being recruited for that particular study and we can get a better data. So this is what we are looking for in future, to look for big data, big study that gives us more valuable outcome, more valuable output of that particular study, and we can conclude conclusively some aspect of that particular research question.
Yes, sir. What you said is really true. Collaborative effect will definitely give valuable outcomes. Thank you for that elaborated explanation, sir. Now, with lot of interest building about the newly launched IJA fellowships, I would request you to share a few insights about the IJA editorial and reviewer fellowships, which is obviously a golden opportunity for the aspiring academic anesthesiologists. So, sir, could you begin by telling our listeners what inspired the IJA to launch the editorial and reviewer fellowships, and what are the key differences between the editorial and reviewer fellowships? And also for young anesthesiologists aspiring to grow academically, how do these fellowships contribute to shaping their editorial and peer review skills?
Absolutely. I think when I started my journey, I did start as an author and then become reviewer, then become the editorial board member, and then become editor. And luckily, I'm today the editor chief. So I think this journey was a long journey of last 15 years. And I think that youngsters can achieve that achievement, not in 15 years, a little faster. So somebody has to mentor them. I have been mentored by my mentors and they have groomed me to this. Why not to put it officially? Many journals across the globe are already providing this type of training program. It's something like an on-job training actually. It is nothing very formal university-based fellowship programs. But then people are interested who wants to get into the business of publishing. That they want to take a leadership role in these aspects also. So that's why I thought why not to start a fellowship. Usually the editorial fellowship is usually being done. To my knowledge, I think reviewer fellowship is for the first time any journal has started across the globe. And the reason why the reviewer fellowship was started, because there was a lot of requests from people to learn the things, how to progress it. Now, once we become editors, we need to understand the basic nitty-gritties across the channel, across the path. I think in life, we always go through the path. Nobody becomes success overnight. Probably it will be a journey where they had put a lot of effort to achieve something. And same journey is for the becoming the editor chief. I understand editor chief is one of the very glamorous and maybe you can say very, I can say proud moment, but then it has to be achieved through a certain path. And I thought, why not to groom the young researchers who are doing good research before they enter into the editorial business? They should also learn the reverse. And there are programs, there are online programs where they can learn reverse. There are many articles. I thought, let them give it a bridge where they can learn how to get the nitty-gritties of becoming a good reviewer. And it definitely gives a lot of you can say superior CV. It makes you more popular. On the other hand, if I see the academic language, it makes you much better uh, researcher. It makes you one of the expert to critically appraise a paper. And when you start critically appraise, your clinical practice obviously becomes good because you know what the world is doing it, and then you can apply to your clinical practice. And when you start applying to a clinical practice, you remain updated. So among your peer colleagues, you will be following the so-called evidence-based medicine because you are keeping updated, and this becomes a tool to learn that. So these are the benefits. So I thought that let the people learn because during my tenure as editor-chief of IJA, many people were requesting me to let them enter in the editorial board. I was little stricter not to allow them because I want that they should have something basic understanding. Because when you enter the editorial board, it becomes a huge responsibility to take decisions on the hard work of the researchers. You cannot say accepted, you cannot say rejected. It has to have a basic understanding. Basic understanding comes when you are a good researcher, you're a good author, and you become a good reviewer also. Then you can become a good editor. So this whole journey, we are doing it. And IJ has earlier started the webinars also where we were sharing the experts' opinion on how to do a good research. So this means IJ is just not publishing a journal of good quality articles, but also wants to create leadership who are interested to enter into the publication business so that they can reach that stage faster. And this is the reason we started with the research methodology workshops, following now the IJ Readership Fellowship and then the IJ Editorial Fellowships, and then my best wishes to each one of you to become editor chief of the journal soon, once I retire from the editor chief post.
Right, sir. Like what you said, with great positions also comes great responsibilities. Sir, could you highlight some of the selection criteria and expectations from the fellows during the 1 year term? And also, I want you to give a postgraduate or a early career consultant who is interested but unsure about their eligibility. What advice would you give them?
Absolutely. I think it is always good, and I have shared a document in which I have mentioned that who are eligible to and what are the criteria for it. But the most important aspect is that you should have passion to do it. It's just not that you just add on to your CV that you are IJ editorial fellow or IJ reviewer fellow. It comes with time. And all my editors into my editorial board, and including me and some of you also who are attached to me as IJ ambassadors, all of you are working and spending a time. Some of my editors, including me, are spending 3 hours, 4 hours, 5 hours for the work itself. So the first thing is your passion. Second thing is how much time you are able to spare for it. So I've already kept it clear that people have to devote at least 5 to 8 hours every week for the journal work. Then only we can learn something. It will not come without time. It will not come without dedication. So I will request whosoever are listening, if they can spare this much of time for the next 1 year, then please do apply. Because though I am not very strict, but I am actually very strict. And I will be strict on these aspects also, that those who enters into fellowship, they will have to contribute to learn the things. Nothing comes free. Everything comes with some cost. And here the cost will be really enjoyable, but the cost will be your dedication, your passion, your readiness to learn, and time to devote, because all of you people are intellectuals people. You can understand the things. It's not a rocket science, but it will take some time. And that is what I will get a commitment before they will be assigned fellowship, that they will commit to me that they are ready to spend 5 to 8 hours a week for this purpose. Number two, I mentioned very clearly that there is a journey. If somebody has, say, one publications and they want to become adult fellowship, I will request not to apply, because by one original article research publication, probably you may not have gained that experience that you can take decision on other articles. At least you have some couple of papers with you. You have already answered the reviewer's marks, you answered the editor remarks, and you have that experience. You have published 5 papers, 10 papers, which I have mentioned as minimum requirement. Then only you can go to the next step. And similarly, a little less for reviewers, but I would suggest that at least the first step will be that you are a good author, well understanding to the nitty-gritties of conducting a research and reporting a research. If not, please do publish some of the articles, then go to the next step of IJA revership, and then next go to the IJA editorial fellowship. So this will be the process. And probably this will be the selection criteria also, which is very well defined in the document that has been shared from the IJA office. And this is almost similar in the template that we have to fill up. So accordingly, you can choose. But remember, before you take a decision on other articles, we also should be well versed about what has been done, what is good and what is not so good. So that comes with experience, and that experience comes with research, and that comes with your own publication. So think yourself, self-reflect. If you're ready for it, please go ahead.
Yes, sir. That was truly inspiring. The future of anesthesiology looks bright in the hands of IJA. I urge all the interested listeners to check out the IJA website and apply before the deadline. Now, let's dive into the academic core of today's episode. We'll be discussing 3 articles from the May 2025 issue of the Indian Journal of Anesthesia, each offering valuable clinical and academic perspectives for the practicing anesthesiologists. To begin with our first article, I'll hand over the mic to my co host, Dr. Poornima, who will lead the discussion on this interesting study.
Hello, everyone. I'm Dr. Poornima. Glad to be back at yet another exciting episode of the IJA podcast. So, let's dig into all the interesting studies that we have in this issue. So, our first article of this episode will be ultrasound-guided subtransverse interligamentary, also called as the STIL block, versus the erector spinae, that is the ESP block, for postoperative analgesia in patients undergoing modified radical mastectomy, a randomized comparative study. So joining us is Dr. Amritha Rath, author of this article. She's an associate professor of anesthesiology at Banaras Hindu University. Welcome to the podcast, Dr. Amritha.
Thank you so much, Dr. Poornima, for the kind introduction.
Yes. Okay, let's dig in. The first question would be, ma'am, your study suggests that the STIL block provides a superior analgesia when compared to the ESP block, likely due to the better paravertebral spread. However, the exact mechanism is still debated, as we know. Could you elaborate on why you think the STIL block achieves a better or a consistent paravertebral diffusion? And do you think it may be volume dependent, or is it related to the anatomical targeting?
Thank you, Dr. Poornima, for that insightful question. Indeed, while both ESP and STIL are classified under the broader class family of paravertebral by proxy, their anatomical targets are distinct, which plays a very crucial role in the quality as well as the consistency of analgesia. This STIL block, as we used in our study, targets the subtransverse interligamentary plane, that is specifically the plane that is anterior to the intertransverse ligament and posterior to the superior costotransverse ligament. So this location places the injected in a very close proximity to the thoracic paravertebral space. That's why it facilitates a more anterior diffusion of the local anesthetic. So the few anatomical studies also suggest that the porous nature of the superior costotransverse ligament aids this anterior passage, allowing the drug to reach both the dorsal as well as the ventral rami more effectively. In contrast, when you look at the ESP, it deposits the local anesthetic further posteriorly, that is beneath the erector spinae muscle. So its efficacy rely on more passive diffusion of the drug across the multiple layers to reach the paravertebral space. Same is even shown by the cadaveric studies that its spread is never so constant until you use a larger volume. So if you see our study, we had used 20 mils of 0.25% levobutyl with Dexa techniques.
Yeah, I think it was very precisely and very neatly put. It's more like we had a clear anatomical imagination as you were explaining this. Moving on, your results also showed that the still block took a significantly longer time to perform. I think with your previous answer, we can imagine how the difficulty would have been. And in a very busy clinical setting, how would you weigh the trade off between the procedural time and the post operative analgesia benefit? Would you still recommend it as the first line despite the time that it takes to perform this block?
Okay. Actually, that's an excellent question and one that resonates with the practical realities of the clinical anesthesia. Indeed, in our study, we observed that still took a few more minutes than to perform a ESP. However, this modest increase in the procedural time was clearly outweighed by the superior analgesia efficacy with the still because they had lower NRS and less opioid consumption. So, in a context of a very busy UR schedule and all, efficiency is still the key, but so is the quality. So, the still, while it requires more precision and anatomical targeting, but it has a better paravertebral spread. Because, as I already mentioned in the previous question, I would say if it's a first line, yeah, if a patient is undergoing a very high pain procedure, like the case of modified radical mastectomy, the answer is yes. Because you need a long lasting analgesia with minimum opioid use, which is more desired. So, over time, as your familiarity and proficiency with the technique improves, this marginal increase in the procedural time becomes actually negligible because you are viewing over the backdrop of improved patient outcome and even the reduced post-operative care. So I think it's still my choice as the first line.
Okay, thank you for that. I think I agree with you, even though we may have a slight longer learning curve for these newer blocks, as long as we know the
Exactly.
efficacy is much higher than what we are comparing it to, I think we can always take a few extra minutes whenever we get on these new blocks. Okay. In your study, you had a few exclusion criteria. One were those with a very high BMI, and then also those who had some vertebral anomalies or deformities. So, given that the patients who are coming with breast cancer usually have multiple comorbidities, how would these exclusions actually impact in the real world? And are there any particular population would you still want to prefer giving ESP, or you would still stick with still block being the best for any kind of population?
Okay. Again, that's a very relevant question. In our study, we excluded the obese patient and those you mentioned with like vertebral abnormalities. And but it was just to reduce the procedural variability, especially considering the anatomical changes that this condition presents while you perform an ultrasound guided block. However, we fully acknowledge that in real world practice, especially in the oncological like breast cancer, this patient have multiple comorbidities, including obesity. So this certainly affects the external validity to some extent. But rather than viewing it as a limitation, I would say it helps us define where caution and further research is needed. Like in such complex patients, especially those with a distorted anatomy or challenging sonoanatomy, I would say we should go for ESP over still, especially in very specific scenario where the performer is not very comfortable or it's a very new to the person who is performing. Because though ESP is less efficacious, still it is superficial. So you have to actually look for the benefit over the like how if you are actually able to perform the procedure or not. Okay. So because I already mentioned, still generally it is focusing on the deeper target. Though there is a reliable paravertebral spread, but at the same time it is very easy in a patient who has a normal habitus. But in an extreme morbid obesity, definitely it can be a tricky position. So ultimately, the block selection is very individualized. You have to balance the efficacy with the safety as well as the feasibility in the patient subgroup. So I believe this actually opens a meaningful direction, like for future trials where we actually can include high BMI patient and those who are anatomically challenging anatomy.
Yeah, I agree. I think you've given us a few instincts on what a future can be with this adaptation of the still block. Moving on, you also mentioned that this is the first RCT which is comparing the still and the ESP blocks for the MRM patients. How do your findings align with other existing data, like you said, the other paravertebral by proxy blocks that are there? And also to add on, in your still block where you have, as you mentioned, the retro superior costotransverse ligament deposition, does it have any added advantage in how the drug is deposited in that?
Okay. So actually, indeed, this is the first CT comparing the STIL block with the ESP block, especially for the modified radical mastectomy. While previous literature, like you mentioned about MTP and CTF block, they have provided some good analgesia or similar analgesic efficacy to thoracic paravertebral. But here the anatomical approach and STIL is particularly this retro-superior costotransverse ligament deposition actually offers a unique advantage. So this retro-SCTL space potentially facilitates the more direct and consistent spread of the local anesthetic towards the dorsal and the ventral rami, closely mimicking it to the mechanism of a true paravertebral block. In our study, this actually translated into a significantly lower NRS and reduced rescue analgesia if you compared with ESP. So, because it is going more precise and more closer to the thoracic paravertebral space, this I would say actually is superior to the rest, despite though they all come under the broader category of ITP block. I hope you're happy with the answer.
Yeah, definitely, Dr. Amrita. I just had this because related to a breast cancer patient. So, in your follow up study, it was basically limited to 24 hours. Given that all these patients are basically for the chronic pain management in the future, do you have any plans on how you would investigate this still block in early analgesic superiority for reducing the chronic pain incidence?
This is an excellent point. While our current study is focused for the first 24 hours post-operatively, where the pain is more acute, we absolutely recognize the importance of addressing the chronic post-mastectomy pain here. Given the promising result with the still block, we are indeed considering a follow-up study to assess what is early analgesic benefit has a downstream effect on the chronic pain development. So, what's the plan is to go for a prospective or a longitudinal cohort or an RCT with a follow up of 1 month, 3 months, 6 months, maybe up to 1 year. And we have to use a chronic pain still like brief pain inventory or the neuropathic pain symptom inventory, along with the sensory mapping to detect if there is any persistent hyposthesia or allodynia. So, actually, we are on the track to come up with another follow up study as well.
I think you have given a window for the listeners if they want to adapt this for their future investigation, which is actually nice and kind of you, actually. To cover up the basis now, in your blog, there is a precise needle placement requirement in the junction. I was viewing the ultrasonic images and I think it's very beautifully pictured in the article. Were there any instances of failure, for example, any pneumothorax, and how do you think, do we have any tools that we can use to improvise and make it more accurate when we are performing these blocks?
Again, this is a very pertinent question, especially given that this still block it is targeting a deeper anatomical space at the SCTL and transverse process junction. In our study, we fortunately encountered no instances of pneumothorax or any block-related complication. However, we do recognize that this safety profile reflects the careful practitioner training and strict adherence to the ultrasound-guided techniques. So, to mitigate this risk, our training protocol emphasized a detailed anatomical understanding, the reliable sonoanatomy recognition, and a bit of simulation best practice. So, if we are more well versed with the anatomy to understand each of the landmarks, sonoanatomy best landmark, we can at least be able to do these perform in a more safe hands. Finally, needle advancement while we used to do a hydrodissection to check for the needle trajectory, doing a negative aspiration as well, and the entire length of the needle, because as you have already spoke about it, so it was an in-plane approach which we are using. Looking ahead, the artificial intelligence assisted ultrasound platforms actually held great promise. This technology offers a real time anatomical labeling, the automated depth and angle recommendations, and even predict these safety alerts. So, if we integrate all these tools, it can actually democratize the access to the complex block, like still, if you say it's a deeper block, especially when the resource, it's a lower resource, or the performer is an early career. So definitely it is going to help us out.
Okay, thank you for that, Dr. Amrita. I know we've already had a few options that you have put in for the future scope of this. Do you still want to add anything that the study can have for the future scope of exploring and maybe further investigating from your end?
Yeah, definitely. I would like to go for, as Dr. Rakesh has already mentioned, we should go for more collaborative study as well. Because as you correctly mentioned, it's a deeper block, inter-performer like will be different, and we have different like higher BMI. We also spoke about the limitation. I think if we come across a collaborative and multi-centric study, definitely the clear picture will be even more clear.
This was quite a thorough and a very insightful conversation with you, Dr. Amrita. Thank you for being a part of this podcast episode again. And it was very wonderful chatting with you. Thank you again. Over to you, Dr. Karthik.
Thank you, Dr. Poornima and Dr. Amrita, for that enlightening segment. Now, let's quickly move on to our second article of the day, which is Impact of Flow Track versus HPI, which is Hypotension Prediction Index, Guided Hemodynamic Management on Intraoperative Hypotension in Kidney Transplantation, which is a retrospective observational study authored by Dr. Saurabh Mittal and team. Dr. Saurabh Mittal is working as a senior consultant in the Department of Organ Transplant, Anesthesia and Critical Care at Mahatma Gandhi Medical College, Jaipur. Welcome, Dr. Saurabh.
Thank you, sir. Thank you so much, sir.
All right, now let's explore how AI-based indices like HPI are changing the perioperative decision making.
Yes.
So, to begin with, Dr. Saurabh, as someone
Yeah.
who has used both FlowTrack and Acumen extensively, I want to begin with a technical question saying, how does the HPI algorithm actually predict hypotension like up to 15 minutes in advance? And what are the waveform features it's trained on? Or in other words, what's happening under the hood when HPI gives a value of like 85 or more?
Yes, sir. It's a very good question. The HPI algorithm basically utilize the machine learning to analyze high fidelity arterial pressure waveform. So it basically process over 2.6 million features which derive from these waveforms. And it mainly focus on the 23 key parameters. For example, like stroke volume variation and the dynamic arterial elastance. So this feature along with the patient demographics like the age and the height and the sex of the patient are input into the computer model, and then HPI will give us a range from 0 to 800. So a higher HPI indicate a greater likelihood of impending hypotensive events. So the HPI alert will came at 85, and so when the HPI exceed 85 for two consecutive 20-second updates and or reaches 100 at any time, basically HPI will update itself every 20 seconds and give us the value. If the value is near to the 100, then it is more likely to be patient will go into the impending hypotension.
That's a brief yet brilliant summary, Dr. Saurabh. So
Thank you,
it's
sir.
exciting that machines are now detecting patterns that the humans eye may miss.
Yes,
Now,
sir.
the concept of HPI more than 85, it's triggering early intervention that is very interesting. So can you walk us through how you interpreted the secondary screen components, like what you have said, stroke volume variation, dynamic arterial elastance, or the rate
Yes.
of change in the pressure over time? You have measured all this. How have these components influenced your fluid or vasopressor decisions intraoperatively in the OT?
Yes, sir. Sir, as far as the secondary screen, so secondary screen provides us the real time hemodynamic data. For example, we stroke volume variation indicates the preload responsiveness. If there is a stroke volume variation is more than 15, so it means patient is fluid deprived. So if the stroke volume variation is less than 10, so a patient has fluid overload, and if between 10 to 15, that means the patient is in gray zone. So the next value is the dp by dt. Dp by dt is basically reflects the myocardial contractility, and we don't have any fixed value of dp by dt, so we take the mainly baseline value at the start of the HPI monitor or the start of the surgery. Then we compare from that baseline value, or we can take 400 as a cutoff of dp by dt. So then the next value is the iodine. Iodine is the dynamic elastance. So the iodine is the ratio of pulse pressure variation upon stroke volume variation. So it's give better value as compared to the alone stroke volume variation or pulse pressure variation, because iodine is also more accurate, and also we can take in the spontaneous ventilation patient So if the iodine is elevated, that is if the iodine is more than zero point 0.9, so it means the patient is the fluid responsive. And if iodine is less than zero point 0.9, it means the map will increase on giving vasopressor, so means patient is vasoplegic. And if the HPI alerts and the stroke volume variation is high, then it is same that if the stroke volume variation is more than 15, then it means patient is fluid responsive. So basically, if dp by dt is less, so that means there is issue in the cardiac contractility, so we have to start inotropes, so inotropes like dobutamine. So with the help of HPI, so we can easily detect the problem is where we can start intervene proactively, that in this patient we have to start vasopressors, or we have to start inotropes, or we have to give fluids. So this is the benefit of this secondary screen.
Yes, yes, I agree with you, and that was beautifully explained, Dr. Saurabh. So it is basically this kind of context-specific guidance which is beyond any warning score. This will actually make HPA a decision-making tool rather than just a diagnostic curiosity. And in your opinion, Dr. Saurabh, what are
Yes.
the most notable advantages of using HPI over flow track in this specific patient group? Especially, you have selected the renal transplant recipients with dilated cardiomyopathy.
Yes, sir. So HPI offer several benefits over flow track, especially in the renal transplant with dilated cardiomyopathy patients. So HPI predict hypotension, as we know, up to 15 minutes prior to the event. That will allow us to proactive approach as compared to the reactive approach. So then second is there is enhancement of specificity of the HPI over uh, flow track during recent studies and during various surgical population. There is also the because the in while using HPI in our study also, we will find that while using HPI we have less intraoperative hypotensive events as compared to the flow track. That duration of hypotension and the severity of hypotension is less in patient in which we use the HPI as compared to the patient in which we use the flow track. So if we detect the hypotension and our approach is the proactive approach, then we will prevent the mainly post-operative events that occur due to the intraoperative hypotension, like post-operative major adverse cardiac events and any episode of acute kidney injury. And especially in this patient, we have to maintain pressure, because the transplanted kidneys mainly depend on the blood flow, because the transplanted kidney is the denervated kidney. So the whole kidney urine production is mainly depend on the blood pressures. So that's why the HPA is the main, and we will find the HPA is better as compared to the flow track in our study also.
Right. I completely agree with you, Dr. Saurabh. So these are the kind of cases where prediction can actually buy you a safer outcome, especially when the cardiac reserve is already low. Now,
Yes, sir.
moving on, how specific was HPI in your experience? Did you find any instances where the index predicted a drop, but the map remains stable in that case? How do you avoid over intervention or giving overflow in such cases?
Yes, sir. Very good question, sir. There may be cases, sir, where the HPI predict hypotension, but the map remain stable. It is mainly due to the compensatory mechanism or other factor, especially in the kidney transplant. There is a technical error or mainly vascular clamping. So vascular clamping or declamping. So during this vascular clamping and declamping, HPI value, we have to also look for the surgical site also, what the surgeon is doing, and is there any sudden bleeding event or any clamping or declamping. So we have to look for that surgical area also. We can't 100% rely on the machine, so that we can overcome by this.
Correct, correct, sir. So that's a key point. So basically, prediction should guide us, but it should not override our clinical judgment.
Yes,
It's
sir.
great that your team treated HPA as a conversation starter and not as a command. Now, moving on to the next question, like what were the practical limitations you encountered with Acumen HPA in the OR? Like either it could be hardware, training, or calibration related. And were there any issues with the data fidelity or lag?
Yes, sir. Sir, as far as the hardware related, there should be ensure compatibility with the existing monitoring systems as well as the calibration. There is regular calibration is necessary to maintain the accuracy as HPI is calibrated every 20 seconds and the data fidelity. So artifact or poor quality waveform can also affect the HPI accuracy and the lag time. There is also lag time, as we know HPI is calibrated every 20 seconds. So if there is sudden event, sudden surgical event, so we have to wait for 20 seconds to calibrate HPI value.
Got it. What you said it is true actually. I think once the teams cross the initial friction and they learn how to set up the equipment and all, the payoff in the real time will definitely be worth it. So moving on, you use time-weighted average (TWA) of the map less than 65 mmHg. This was your primary outcome in your study. So just for the sake of our listeners who are unfamiliar with TWA and area under threshold (AUT), could you explain why this metric was chosen over a simple metric like a map reading? And how does it better reflects the clinical burden of hypotension?
Yes, sir. Sir, I can explain in the simple words that time weighted average of map less than 65 of Hg quantify the cumulative duration of hypotension. Like in our paper, we use the flow track and the HPA. We compare the flow track and the HPA. So the patient in which the hypotension occur, that is same. That is the five patients is same. Our flow track group also 5 patients had hypotensive event, and also in the HPI also 5 patients had hypotensive event. The difference between hypotension in the flow track group or HPI group is that the severity of the hypotension or the basically duration of the hypotension. So the duration and severity of the hypotension is more in the flow track group as compared to the HPI. So that with the help of HPI we can decrease the duration and the severity of the hypotension, and we can reduce the post-operative major adverse cardiac events or any post-operative events that occur due to the intraoperative hypotension.
What you said is absolutely right, Dr. Saurabh. It's a valuable explanation. And from a broader perspective, how would you advise a medium volume center or a small volume center? Because everybody cannot afford a machine like Acumen, but
Yes,
they still want to minimize the intraoperative hypotension. So can some of the learning from your Acumen protocol be translated into standard goal-directed therapy with the available monitors?
Yes, sir. Sir, goal-directed therapy using standard monitor to guide fluid and the vasopressor therapy based on the parameters like the pulse pressure variation that we have in the operating room. Now we have a standard Philips monitor that have a function of pulse pressure variation with the pulse pressure, because pulse pressure variation is also a dynamic indices, so we can better predict the hypotension, or we can better predict that patient wants fluid or vasopressor. Or education and training is also the main component. If we ensure the proper education and training to every staff, and so in recognizing the hypotensive events, so that we can respond to early to the hypotension, or we have to make habit to always see the surgical area also that is bleeding, and any events, any technical event that occur in the surgical field also. When we combining these all, so we can also, if we don't have the HP, then also we can prevent the hypotensive events.
Yeah, well said and well answered, Dr. Saurabh. Thank you for the enlightening discussion and very elaborated explanations for all the questions. Thank you so much.
Thank you, sir.
So, moving on for our final segment, we turn to another promising topic that is sure to interest both academicians and clinicians. I now hand over to Dr. Poornima to lead this discussion.
Thank you once again, Dr. Karthik. Let's jump into the last article for today's episode. The article is Effect of Bilateral Intranasal Transmucosal Sphenopalatine Ganglion Block on Intraoperative Fentanyl Requirement in Children Undergoing Palatoplasty Under General Anesthesia. And with us today, we have one of the esteemed authors, Dr. Devang Bharti. Welcome, sir. And he's the Assistant Professor at Maulana Azad Medical College and Associated Hospitals. A warm welcome to you, Dr. Devang.
Thank you, Dr. Poornima, Dr. Karthik, and Dr. Rakesh sir for having me on the esteemed IJA podcast. And it truly is an honor to be part of such a distinguished platform. Thank you.
We are also very glad, Dr. Devang. So let's dive in. I'm excited for many of the questions that I want to be asking you. So to start with, what sparked this study? The sphenopalatine ganglion blocks aren't exactly mainstream in case of pediatric palatoplasty. So what inspired your team to explore this technique, and were there any gaps in the conventional analgesia that you were hoping to bridge?
Well, actually, the inspiration for this study came from a completely different clinical context. We had used intranasal sphenopalatine ganglion block in a patient with post-dural puncture headache. And the simplicity and effectiveness of that experience stayed with us. That actually got us thinking, could this be applied in other areas where SPG is relevant, like cleft palate surgeries maybe? Palatoplasty, as you know, is an extremely painful surgery because palate is so richly innervated. Managing analgesia in children with cleft palate requires a very delicate balance. On one hand, we need to ensure adequate pain relief to prevent agitation and bleeding, and on the other hand, excessive use of opioids can lead to respiratory depression and airway compromise. Traditionally, yes, peripheral nerve blocks like greater and lesser palatine nerve blocks and suprazygomatic maxillary nerve blocks maybe have been used. These blocks offer excellent analgesia, but are technically demanding and often require ultrasound guidance. Now, not all centers have immediate access to ultrasound or the expertise required for performing these blocks. And this is especially relevant for cleft surgeries, as many non-profit organizations are conducting these surgeries in remote, low-resource areas. So basically, we were looking for something which was simple and safe. So that's what made the intranasal transmucosal route so appealing. It is quite quick and does not require any imaging or any invasive instrumentation. So really it was a combination of maybe clinical curiosity and a desire for simpler, safer technique which sparked this study.
That was very well put, Dr. Devang. I think the accessibility, as you said, in remote areas for such conditions is absolutely not very easy. And also the feasibility to perform those minute blocks which require very high precision also has a very longer learning curve probably. And you have actually developed a very approachable, and I think someone can pick it up confidently if they want to try it, even if it's the first time that they are doing. Moving on, you used your blind intranasal transmucosal approach, as you said, and you used applicants which were soaked with bupivacaine. Given that all these children have a very wide anatomical variation, how confident are you that this technique can be produced in all kinds of institutions? And did you approach any step where you had any failures or any difficulty? And if you had to overcome that, how did you do that so that our listeners, when they want to try, they can have an insight on this?
See, that's a very relevant concern, and it's something which we considered seriously while designing the study. In fact, this question was even raised by one of the reviewers while our manuscript was undergoing the peer review process. So you see, the intranasal route using a cotton-tipped applicator might initially sound imprecise, especially when we are dealing with pediatric anatomy, which is known to be very variable. But what's reassuring is that the target, the sphenopalatine ganglion, is actually quite accessible, as it lies just behind the posterior wall of the middle turbinate. Even though the technique is blind, it relies on the consistent anatomical landmarks. The applicator is simply advanced along the superior border of the middle turbinate until it meets resistance, which corresponds to the posterior wall of the nasopharynx, and that's exactly where the SPG lies. So, despite minor anatomical differences, this endpoint is generally reproducible. Now, from a practical standpoint, the technique was found to be remarkably easy to learn and apply. And with experience, while we were performing these cases, we could even standardize the technique in terms of what direction to take, the depth of insertion and approximate depth of insertion, and the dwell time. So, and importantly, we did not encounter, like you were asking, we did not encounter any complications or any incidents of block failure, which was quite reassuring. But having said that, we do recognize that in certain patients, say those with associated craniofacial anomalies, very severe septal deviations maybe, or cases where cleft lip is associated with the cleft palate, this blind advancement may be a little less predictable. But for such cases, if there is any doubt about the placement, the position of the applicator can actually be confirmed endoscopically, either through the nostril or even through the palatal defect itself. One could argue that using endoscope does require a certain level of expertise and specialized equipment, but I feel it is still significantly less demanding than what's needed for ultrasound-guided invasive blocks. So, Overall, while the blind technique is quite robust and sufficient for most of the children, having the option to visualize and confirm placement endoscopically, I think it adds an extra layer of confidence.
Okay, thank you for that, Dr. Devang. I was actually having a thought how maybe we could overcome it, and given the idea of an endoscope or maybe a fiber optic is actually a very good thought. Someone who has been maybe trying for the first time, or as you said, with severe defects that needs actual assistance, I think this would be a very ideal approach along with the tools that we have. Moving on, your study reports a statistically significant reduction in the intraoperative fentanyl use. So, from a clinical standpoint, how meaningful is this in terms of patient outcome, especially as you mentioned the respiratory safety and also the post-operative recovery?
Well, as you said, the statistical reduction in intraoperative fentanyl use was quite evident in our study. And what makes it more impactful is how this statistical significance translated into practical and patient-centered benefits. In pediatric palatoplasty, as we discussed, airway is always a concern. The airway is challenging and they predispose to airway obstruction and respiratory compromise. So being able to provide effective analgesia while using less opioids has, I think, very real advantages. In our study, this reflected intraoperatively as more stable hemodynamic profiles. But the most crucial difference was seen post completion of the surgical repair. Children who received the SPG block had smoother extubations and far fewer airway interventions or manipulations. No apneic episodes were observed in the recovery room. And then there was a significant difference in the pediatric anesthesia emergence delirium scores post extubation. Children who received SPG block emerged more calmly with very little agitation and discomfort. And as we just discussed, this is extremely desirable in cleft palate surgery where post-operative agitation and bleeding will lead to catastrophic complications. So yes, the statistically significant reduction in fentanyl use did translate into a measurable improvement with respect to perioperative stability, respiratory safety, as well as post-operative recovery profile.
Okay, that was very nice, Dr. Devang. I think, as you said, the post-operative recovery is very crucial for us. And when we look into these children with forced palatoplasty, we're always worried in many terms. And I think, as you said, knowing that we can avoid intraoperative fentanyl, it gives much more confidence for us as practicing anesthesiologists. Moving on, you also mentioned in the previous answer about the smooth emergence. So your study also mentioned, as you said, positive scores in terms of emergence delirium. What, according to you, could be the reason? Is it only because of the pain relief, or do you think there is any neuromodulatory effect that is happening because of the block that is being done?
Well, yes, we did find PEAT scores were significantly lower in the SPG group, both at 5 minutes and 10 minutes post extubation. Now, the immediate explanation was better analgesia, which reduces pain-related agitation at emergence. But as we analyzed the results and we came to know about the degree of difference in the scores between the groups, this actually made us wonder if there is more at play. Perhaps a subtle central modulatory effect of the block itself, because anatomically the sphenopalatine ganglion is a part of the parasympathetic nervous system, and it does have afferent and efferent connections that could potentially influence autonomic tone and maybe the central sensory processing as well. Blocking sensory input at the ganglionic level might modulate central responses indirectly. We did think about that. Although this mechanism remains speculative at this stage, if validated, it could have a very significant impact on the recovery protocols in the pediatric anesthesia. It may actually reduce our reliance on the sedative agents. The block itself is doing that. And it would avoid polypharmacy and obviously minimize sedation related complications. And if we take this further, in practical terms, this could translate into faster recovery room discharges, earlier initiation of oral intakes, and maybe potential early discharges in selected cases. So yes, it would be quite beneficial.
Yeah, thank you for that, Dr. Devang. And I think you again opened up a series of opportunity for the viewers and listeners if they want to explore the similar block, maybe with different primary outcomes. I think it would be interesting to know more about this now. You also mentioned that the postoperative pain wasn't formally assessed and the sample size was also limited. If there was an access for much more resources and a multi-centric design centers, how would you redesign the study or reapproach this entire procedure?
Well, yes, our current study was conducted at a single center with a relatively small sample size, and it primarily focused only on the intraoperative parameters. So there's definitely scope to expand and strengthen the design. If we were to redesign it with adequate funding and a multi-center setup, the first major change would definitely be to include post-operative pain assessment as a formal outcome. We will assess pain for maybe 24 to 48 hours post-operatively using any of the validated pediatric pain scales. That would give us a clear picture of how long the block's effect truly lasts and whether it reduces the need for opioids post-operatively as well. We could substantiate, we could prove that it was reduced intraoperatively, but yes, does that translate into the post-operative reduction as well? The second would be to include a third arm using an established peripheral nerve block technique. And this is again one thing which we discussed a lot at the time of inception of the study. We would not only compare the efficacy, but also compare the blocks in terms of the time taken, rate of failure, and the complication profiles of the two blocks. Another valuable addition could be that instead of only comparing PED scores, we could maybe objectively assess individual recovery room outcomes, like time to extubation, maybe time to oral intake, the length of PSU stay. All these practical recovery endpoints will give us a better picture regarding the post-operative recovery profile of the patient, and perhaps assessment of the child and parent satisfaction as well, because truly that's what our ultimate goal is. And of course, increasing the sample size and roping in multiple centers will make the results more generalizable across various populations. So with expanded resources, we would aim to make our study more comprehensive, more comparative by including additional groups, and more practical outcome focused across an expanded perioperative period.
Okay, thank you for that, Dr. Devang. I think, as you said, knowing the parent satisfaction is actually a direct correlation to the patient satisfaction here. And I think you again opened up a lot of opportunities to further take up this study if anyone and everyone is interested to go ahead in this. To cover the base, considering that we are now moving mostly into opioid sparing anesthesia, where do you see the sphenopalatine ganglion block fitting into the protocols of pediatric anesthesia? And what kind of challenges you would foresee in implementing this on our broader platforms?
Well, I see SPG block as a promising addition to the existing modalities. It offers a simple, safe, and efficient technique which can contribute meaningfully to reducing intraoperative opioid requirements. And its real value, as we have discussed, lies in its practicality. Unlike other peripheral nerve block techniques, intranasal transmucosal SPG block can be performed quickly with minimal resources and expertise. Now, as far as it becoming a standard practice, I do hope so. I believe it certainly has the potential. But like with any new technique, there are a certain barriers like maybe lack of awareness, gap in training, although it does not require much of training, but still people need to be exposed to it. And like with any other new technique, hesitation to adopt a new approach, that is always there. But that said, I see these barriers as relatively minor. With a growing emphasis on opioid sparing anesthesia, I'm confident that SPG block will gradually find its place, and particularly in procedures like palatoplasty, where the clinical rationale for its use is especially strong.
Thank you, Dr. Devang. I think I completely agree with you that SPG block is a eye opener for someone to approach it. Much more easier learning curve, as you said, and very promising results, and also with a very high scope for the future studies, as you have mentioned. Thank you again. It's been a very truly insightful conversation with you. Very convincing. I think anyone would hear to this and want to go put their hands into trying this method, especially. Thank you for joining us, and hopefully we get to collaborate more with you in the future. Over to you,
Thank you,
Dr.
Dr.
Karthik.
Poornima. Yeah. So thank you, Dr. Poornima. Also, thank you, Dr. Amritha, Dr. Saurabh, and Dr. Devang for your time and sharing your research stories with our listeners. So, before we wrap up, Dr. Rakesh sir, do you have any comments about the articles or any message to the authors and listeners?
I think at this juncture, I will also say that the IJA will be publishing a themed issue, which will be on facial pain blocks for adults and pediatrics. So anybody have interesting articles, definitely it will be going through the same process of peer review and final decision. If somebody has good narrative review with expertise, they are most welcome to submit. The last date is 31st August 2025. And the whole issue will be on facial pain blocks. And with this emergence of facial pain blocks, we were talking about opiate sparing, anesthesia, multimodal analgesia. we need to understand the usefulness of these blocks for various aspects. Facial plane blocks are good, but we need to understand the anatomy and the distribution of the nerves that are bathed in those facial plane blocks. At times, there will be areas which are spared and they may require combination of drugs or additional analgesics. Sometimes people report the cases that they try to do certain case into a single facial plane block without considering that certain areas may not be anesthetized if you use those single plane block. So try to understand the anatomy, which all nerves are there, and then try to take a decision that whether you need to use combination or the facial plane block will be one of the requirement, one of the component of multimodal analgesia, so that patient remains at comfort. And this understanding is very important when we venture into new things. And similarly, various facial plane blocks are being named and renamed. When more is being looked into the anatomical variations, the anatomical distributions, better understanding it is coming up. And with the availability of ultrasonography, I have mentioned it in an earlier podcast also. As we used to do for plexus block, where we used to see that the plexus is bathing into the local anesthetic agent for its good efficacy. It's a time to look for a facial plane, though we say that a facial plane block, the identification is on a singularly site where we puncture a needle and inject the drug. We do not know exactly that how much time does it take, what volume is required for bathing the whole facial plane. So this is one area which is a little novice. Can we scan the ultrasonography into the various positions where that plane exists? Is that window available? That is one area which is open for researchers, that can we do a dynamic facial plane block? Right now it is more of a static facial plane block. So that dynamicity is a future research looking for today's understanding, and with this themed issue, people can submit articles in regards to this. Secondly, we also need to think for, as we say that whenever we do something with the body, it needs to be fibrous. And once the facial plane block has been given for a particular study, for a particular operation in the surgery, will that facial plane for future surgeries also, because some amount of external interference has been done. We do not know whether it leads to inflammation, but there are studies which says once you give something, there will be some amount of bodily response, and that may lead to adhesions and closure of the facial plane blocks. We do not know that repeat procedures in the same facial plane will give the same leverage, and hence we need to have something to do hydrodissection. Do we need to do hydrodissection for those facial planes? Another area of research we can think of. So many things are coming on facial plane blocks. I think it's a good field. People are using a lot of adjuvants. They are putting everything into these facial planes. But also remember that certain drugs are not approved for its clinical uses. They are being given approval for research purpose also. So when you go into a clinical practice, say for example, facial plane block, dexmedetomidine has never been approved for clinical uses in routine practice. It is just a research molecule. So if you are using for your patients wherein the drug has not been approved for its route, please be cautious. It has to be with consent, it has to be under research, it has to be ethical approval. Be very careful when you start using drugs which has not been approved by the drug authorities before you do it on clinical cases, because we do not know whether it has some implication, whether we need to observe for some complication. So be careful and try to keep them under the research preview, so that once we are conclusively confirmed about its beneficial effect, it will definitely come into clinical uses. So with this, special thanks to today's authors, Dr. Devang Bharti, Dr. Saurabh Mittal, and Dr. Amritha Rath, for a very nice
Thank you so much, sir.
discussion and bringing out the nuisance. I'm sure researcher takes over 1 to 2 years to uh, understand that particular research. They have spent a lot of hard work, and that's why IJ always encourages, because IJ gives them 2,500 to publish, 2,500 words to publish their work. But I think in their mind it will be more than 25,000 ideas and words in their mind. So that's why we try to explore those unwritten manuscript publication in IJ to come to podcast. And it has been excellently done by Dr. Poornima and Dr. Karthik. Thank you, both of you. You are our IJ podcasters, and special thanks to both of you for taking it in a lovely way and taking out some information from the researchers' great helps, so that the whole academics is beneficial from their hard work. Thank you, everybody. And last word over to Karthik.
Thank you, sir. Thank you.
Thank you, sir.
Thanks a lot, sir. This new chapter of IJA will definitely create a greater motivation for the regional anesthesia enthusiasts for research in the facial plane blocks for pain management. And to all our listeners, we encourage you to check out the IJA website and explore the IJA fellowships and submit your best research. Before we wrap up, I would like to make a small but important request to all our viewers and listeners. The IJA Podcast YouTube channel is a gold mine of academic content from anesthesiology, with episodes that dive deep into the latest research, clinical pearls, and obviously the expert insights. But it's still underutilized by many in our community. If you find today's episode valuable, please share it with your colleagues, residents, and friends. Let's spread this knowledge wider, because good research always deserves to reach every anesthesia professional out there in the country. So until next time, you stay curious, stay evidence-based, and stay connected with the Indian Journal of Anesthesia. Thank you for listening.